Anyway, Parkinson's disease. So, neurological disorders are common. Okay, so this was a slide from Southeast Coast's work that they did, looking at the whole of the neurological sort of scene, if you like. And apart from the fact that neurology is very common, it's very debilitating and it's very costly. And has a specialty that deals with a lot of chronic neurological disorders. Because the population is aging, we are going to see more and more older people with neurological disorders, which actually we as neurologists are diagnosticians, but we're not particularly brilliant when it comes to the kind of looking after. And that's where guys like you are so important. Okay? So when the PCT or the CCGs are looking to spend their money, I think you need some very strong voices to say, we are money well spent, because consultant neurologists are expensive. And yes, we do the diagnostic bit, but actually you make a real difference in terms of quality of life and management of patients with chronic diseases. So about Parkinson's disease. So idiopathic Parkinson's disease is about Lewy bodies. And Lewy bodies are just a kind of neurodegenerative remnant. So they're just what's left over when bits and pieces in the cell degenerate but don't get cleared away properly. And in the end, they end up poisoning the cell. So they switch on all sorts of switches within a cell, and that ends up in cells degenerating. The problem is with Parkinson's, idiopathic Parkinson's disease, we often get it wrong. And there was a great pathological study done 20 years ago now, which looked at people who came to post-mortem and had a diagnosis in life of Parkinson's disease. And in fact, pathologically, up to 10% of those people were misdiagnosed. And in fact, even 5% of those people were misdiagnosed by neurologists. So it can be difficult to make a proper and definite diagnosis of Parkinson's disease. And thankfully, the statistics are in our favour. So actually, when we see people with Parkinsonism, mostly they're going to have idiopathic Parkinson's disease, which is a common disorder of aging. Excuse me. There are, of course, the sort of Parkinson's plus syndromes. So there's this, which is multi-system atrophy, and then there's this, which is progressive supranuclear palsy, and I don't think I put it in there, but there's CBD, which is corticobasal degeneration, and then there's other things that masquerade like Parkinson's disease. Where do you think we'll see most of the drug-induced Parkinson's? Anybody? It's usually neuroleptic drugs, so you'll see them on psychiatric wards. But in fact, again, fewer and fewer patients presenting like that. It's a common disorder, all right? And if you look at the overall epidemiology, about 1% of the global population is affected by Parkinson's. That's a huge burden of disease if you think about it. And this is just a slide I nipped off the government website, the Office for National Statistics, and you can see just here in red that actually, as the years are going on, we are getting more and more older people. So we're sort of from 75 through to 2045, we're almost doubling the percentage of patients over 65 years of age. So it's a progressive disorder, all right? And the problem with Parkinson's is that we can often deal with the symptoms, but as the years go on, it's not just a motor disorder, it's a disorder which is characterized by non-motor symptoms, which are quite difficult to deal with. And when we look at some of the non-straightforward Parkinson's conditions, such as MSA, PSP, people have a shorter lifespan. So in general, you can knock off about 10 years of life if you develop idiopathic Parkinson's disease. If you have PSP or MSA, you're looking at shortening that, so median survival from a diagnosis of PSP is about 5 years. From a diagnosis of MSA is about 10 to 15 years. So you're knocking off a significant amount of years of life, and quality life at that. And this is just a slide to show you that what a Lewy body looks like. So when we look under the microscope, if you look at a normal person, so these are post-mortem specimens from people who didn't have Parkinson's, the substantia nigra, so-called because nigra black, has got lots of dopaminergic producing cells, and those project into the sort of brain stem. In patients with Parkinson's disease, degeneration of those cells leads to loss of those cells and then washout of the substantia nigra. Okay? So that's the primary pathology, loss of these nigral cells. This is really a complicated slide, and I just put it up there. If anybody's interested in reading about it, it's in the references there. But basically, it's interesting that, in fact, Parkinson's disease, we all think of it as a brain disorder. Well, it is a brain disorder, but it starts in neurons, not just in the brain. And in fact, there's now evidence that Parkinson's disease starts in neurons in the gut, so you can find changes in gut neurons from an early stage. Have you heard people say, my sense of smell has changed? These are Parkinson's patients. Well, actually, loss of sense of smell can predate the onset of motor symptoms by 10 to 15 years. So there's evidence that the sort of nerves involved in smell, perception of smell, get involved with this pathology earlier than the motor nerves. So it's a complicated condition, and it affects lots of other systems, not just the primary motor system. I've only put these in quickly because this is what a normal this is the functional anatomy of the motor system. And really, on here, I just wanted to point out that dopamine is the main sort of neurotransmitter within the primary motor system. Okay? And there are lots of positives and negatives, stimulation of the subthalamic nucleus, positive and negative, and it's a balance, right? And in the patients with Parkinson's, because we lose the effects of dopamine, we change the balance. Okay, there's an indirect and a direct stimulating system within the motor system, and when we change the balance of that, we start to get the motor problems of Parkinson's. This is really a complicated sort of basic science slide, and it's just there out of interest. Parkinson's disease, what do we know about risk factors? Well, old age. Okay, so as we age, we're going to see more and more patients with Parkinson's disease. There is some evidence of genetics, but actually it doesn't run in families. So most people who come along and they're worried because they've developed a tremor and grandpa had Parkinson's disease, actually the risk of that tremor evolving to Parkinson's disease is of the order of 5% or so. There's been, over the years, many sorts of risk factors looked at, including exposure to herbicides, so farmers, pesticides, heavy metals, etc. None of this has been really well proven. And the only fact which does come out in study after study is that smoking can be protected. Not that I'm advocating smoke, but certainly that's the only thing that's been done. So at the end of the day, it's a little bit like a lot of neurological disorders. It's genes, it's environment, and bad luck. Being in the wrong place at the wrong time, something triggers the switches, and then that cascade starts, the neurodegenerative cascade. So I think I'll pass over that slide. It's in your handouts. And in terms of symptoms, so the cardinal symptoms, tremor. So I think you guys, GPs, lots of other people referring to us, people with tremor. Okay? And most people over 50 are going to worry that they've got Parkinson's disease. Is that right? Is that your experience? Certainly, that's what happens when they come to the clinic. They think they've got Parkinson's disease. Okay? So tremor is one of the cardinal symptoms and signs. And the characteristic of the tremor is a resting tremor. So it's sort of, you're sitting watching TV and there's a bit of a tremor going on like that. All right? Mostly, it doesn't interfere with activity. So you can sort of, they can use a screwdriver, they can use a knife, they can do most tasks without it interfering. However, the fact that the tremor may occur if they're holding their arms up or they're doing a task doesn't exclude Parkinson's disease. So it's only one aspect or one symptom and one sign. Bradykinesia is the key. So the thing about Parkinson's disease, if you take anything away, it's about slowness. Okay? It's a disorder of slowness. And bradykinesia just means slowness. And what it specifically means is slowness with repetitive activity. So when you ask patients, how does it affect you? Well, they'll say things like brushing your teeth. Now, I know most people now have an electric toothbrush, but if you're using an old toothbrush, you find it more difficult as the task goes on. Combing your hair, all right? More difficult. Repetitive tasks, basically, shaving, things like that, stirring a pot. Okay? These are all the sorts of symptoms that patients may say, "Yeah, I'm finding it more difficult." And stiffness or rigidity, all right? And I've put postural instability in brackets because people with Parkinson's disease, common garden disease, don't come along to the clinic in a wheelchair. Not at the start, anyway. They certainly get postural instability later on, but if they come to the clinic and some of the early symptoms are falling over, think about other things. Think about one of the Parkinson's plus syndromes, because that's more likely than idiopathic Parkinson's disease. Other things, micrographia, just handwriting gets smaller as you write, masks face, so less expression on the face, stooped, shuffling gait. You know, I used to be the one who was out in front, but now I'm dragging after my wife or my husband. And you might find a decreased arm swing. Okay? Has anybody seen this decreased arm swing? You see that? Okay. It's probably one of the earlier things you might spot. You as physios might spot. The patient may not necessarily bring it to your attention. And why do you think they've got a reduced arm swing? Sorry?
Because of the rigidity.
Yeah, they're stiff. Yeah. So if you get somebody to stand like this and you move them around like this, the non-Parkinson's arm will swing freely, and the other side will be stiff and won't swing so much. It's just the stiffness. Okay. I thought I'd put this in because REM sleep behavior disorder. So what's REM sleep behavior disorders? When we're dreaming, REM sleep, rapid eye movement sleep, we lose muscle tone. Okay? Well, that's because we're dreaming. So if we retain muscle tone, we might do all sorts of things and act out our dreams. So it's a sort of protective mechanism in a way. And REM sleep behavior disorder is when we lose that disconnection and people sort of thrash out in sleep, act out their dreams. Okay? And it's thought that REM sleep behavior disorder actually can be a marker for Parkinson's disease. And indeed, there are lots of studies now coming out which are showing that if you look at patients who start off with REM sleep behavior disorder, between 10 and 15 years later, a majority, 70% plus, have developed Parkinson's disease. And I'm talking about patients in their 50s and onwards. Okay? So it's actually a useful marker and something you could ask about, you know, what's your sleep like? Do you have to go and sleep in a separate room because you're sort of beating up your sleeping partner every night? For one reason or another. Right, now, what about signs? So, we talked about tremor. I'm not sure if this is going to work. Let's try. So this is a hill rolling tremor, so a resting tremor. The characteristic is pill rolling. This is testing bradykinesia. I'll come back to those slides in a moment. And this is showing you a man with rigidity in his arm. You can make it more obvious by getting them to do a distracting task, synkinesis. So I'm sure you've all had patients like this, you've sort of appreciated the rigidity. So hill rolling tremor is this sort of thing. Okay? You can sometimes see it when they're walking. The arm doesn't move and there's a bit of hill rolling going on. Okay? And then the bradykinesia, get them to do any repetitive task. And the affected limb, you'll find that the movements start to get smaller and harder to do, whereas the other side is fine. Okay? And when you're looking for rigidity, if you think, that arm's not moving so much, but you examine them on the bedside, in the couch, whatever, on the couch, whatever, and you think, well, I'm still not too certain, get them to do a distracting task, and you'll find that you can bring out the rigidity that's there. All right? And that gives you all the clues you might want. One thing I would just say to you, and I know you're not all sort of diagnosing Parkinson's, but for those who might be GPs here or whatever, it's a disorder that starts in an upper limb. Okay? It doesn't start from the legs. Walking difficulties, yes, but you don't find people who come in and say, my problem is that I walk like this, but their arms are fine. Okay? Lower body Parkinsonism is probably due to something else, like vascular disease, perhaps a tumour, or hydrocephalus. So always one arm, later spreads to the leg, and then becomes bilateral. Okay? So that's the sequence for idiopathic Parkinson's disease. If it doesn't start like that, then think of something else. So additional signs and symptoms, difficulty rising from a chair, you probably see that all the time. Soft voice, again, common. Production of saliva, so a bit of drooling, that's not uncommon. And I said loss of sense of smell. And foot dystonia. Do any of you have patients with foot dystonia? Are you dealing with patients with foot dystonia? Yeah? So they go along, they're walking along, and the foot sort of pulls in like this, or the toe points downwards. It's quite painful. Okay? And that can be an early but also a late sign of Parkinson's. And something that can be quite difficult to deal with, but is usually a problem with lack of enough dopamine. So it comes down to titrating levodopa dose. Just on this side, actually, if you look at sort of things that might suggest the condition other than idiopathic Parkinson's disease, eye movement disorder, all right? People with Parkinson's disease don't have an eye movement disorder early on. So eye movements are normal. People with supranuclear palsy have difficulty elevating the eyes upwards and downwards. Okay, so elevating and depressing the eyes. So vertical gaze palsy. People with multisystem atrophy, there may be cerebellar signs, okay, in coordination. All nice and early, these signs occur with the Parkinson's. Early falls, again, a clue that this may not be idiopathic Parkinson's disease. So early symptomatic postural hypertension, you stand up, you fall over because your blood pressure doesn't follow. That comes later on in Parkinson's disease, but not early. Okay, so there are clues that this is not idiopathic Parkinson's disease. I will leave those for you to read in your slides. But as you can see, there are a number of conditions which can present like Parkinson's, in other words, slowness, stiffness, difficulty doing motor tasks, but there are lots of other features. Okay? And what about the differential? Well, there's a long differential, okay? And there are lots of different things that can produce slowness, stiffness, but there are clues. And to a neurologist, there'll be all sorts of clues that we'll pick up in the clinic, and there are things that you might see and you might write to us and say, I'm not too sure that this is Parkinson's disease. I found this in the patient. Would you mind having a look at them again? Okay? And I think it's this. I put this slide in about antipsychotics, and I only put it really to just bring this to mind, because sometimes we do come across the odd patient where nobody's really thought, maybe it's the drugs. Okay? Psychiatrists have been switched onto this for some years now, because we neurologists have sort of gone on and said, well, come on, wake up, you must know it's the drugs, do you? But you might actually think sometimes when you've got a patient in your clinics, could this be the drugs that are making them slow, giving them a bit of Parkinsonism, particularly if they've got neuroleptic drugs, psychiatric patients. Just think about that, and you might want to sort of flag that to the psychiatrist or to the neurologist. This is another rather sort of laboured slide. It's in your set. I just wanted to put this here about vascular Parkinsonism. This is one of the sort of common pitfalls, is that, as I said to you, patients who sort of have difficulty walking and have this kind of dyspraxic, small stepping gait. Okay? If there aren't any other upper body signs, always think, could this be vascular Parkinson's? What are the clues? The clues are that there may be an abrupt onset, there may be a stepwise progression. In other words, they have some kind of vascular event and they have another vascular event, and that might be the clue. So there'll be event after event and the emergence of this kind of dyspraxic gait. And then obviously doing a bit of brain imaging might help. There are other reasons why people might have Parkinsonism, so hydrocephalus is a cause. What about, can we tell the difference between Parkinson's tremor and essential tremor? Well, sometimes it can be difficult. So I can remember a patient who I thought, he's got Parkinson's disease, he has a tremor. And the tremor started on one side and became bilateral. Well, so can essential tremor. And the thing about it that was different was that 5 years down the line, he was still pretty mobile and still able to do most things, other than the tremor interfered with sort of ADLs. And so the clue is that often with essential tremor, the tremor may get worse, but they can still walk normally, and they don't have the emergence of the other features of Parkinson's disease. So the key is this Parkinson's disease? Is it evolving like I would expect Parkinson's disease? If it's still just only tremor, then maybe it's essential tremor. Parkinson's disease. In 1967, I think it was, that's when levodopa first appeared. And prior to the use of levodopa, survival wasn't great. People used to end up in wheelchairs, they were stuck in wheelchairs, and they had all the complications that came from being immobile and stuck in a wheelchair. As soon as you gave them levodopa, people were starting to get a lot more mobile. Right? There's a great video, which I think is on the internet actually, of somebody who'd been in a wheelchair for many years, and they took levodopa, and literally, Lazarus-like, got up and walked. Okay? So it's a great drug. And all it's doing is replacing the levodopa that your brain is not making. Do we have any preventative treatments? Well, currently, for all the neurodegenerative disorders, so I mean, all the dementias, motor neuron disease, multiple sclerosis, which is inflammatory and neurodegenerative, there are no neuroprotective drugs. So you can safely say to patients, whether I diagnose you today or in 2 years' time, unfortunately, I can't give you any medication that's going to make a difference to the long-term outcome. So if you're going to be disabled by your condition long-term, that's unfortunately what's going to happen. So that's true for all the neurodegenerative disorders. However, we're pretty good with symptomatic treatments, okay? And in Parkinson's, the advent of levodopa treatment, Sinemet, Manipar, has been great. It's actually revolutionized the treatment of patients and still is gold standard. This is an area of increasing interest, management of non-motor problems. So all the sorts of problems with erectile function, well, basically autonomic function, mood disturbance, and sleep disorders. These are all part and parcel of Parkinson's disease, and actually there's now a lot more interest in how can we improve quality of life by addressing these issues, something we didn't used to spend much time doing. Restorative treatments, that's really experimental. I think it's watch this space. You probably all hear about every other month, you know, stem cells for MS, stem cells for Parkinson's, stem cells for everything. Well, I've kind of heard that story for 15 years, at least 20 years, and we're still at the point of, yeah, there are some animal models, and yes, there are a few limited trials on human beings, and no, we're a long way off getting it from the bench and into the clinic. So I'm afraid stem cells is a long way to go. Neurotrophic factors, so trying to kind of regenerate parts of the brain that are degenerated using brain-derived growth factor, nerve growth factor, etc. These sort of experiments have gone on for a long time. Again, it's a bit like stem cells. Theoretically good, some animal models, but a long way off from coming into the clinic. So in terms of treatment classes, we use dopaminergic drugs, basically. Just put back what there isn't. So there's a lack of levodopa, let's put that back. Admittedly, we do it non-physiologically, but it works well in the early years. And then there's these other sorts of drugs, so catechol-methyltransferase inhibitors. I mean, basically what these drugs do is that they stop the breakdown of dopamine in the brain. So in other words, whatever dopamine there is there, these drugs prevent it being broken down, and therefore it has a longer duration of action. And then anticholinergics and amantadine, they work on slightly different parts of the whole motor system. They're not great. This is a complex slide that just shows you that in terms of signaling, there are lots of different chemicals involved. Dopamine, however, remains the main neurotransmitter in the motor system. Anticholinergics, they've been around a lot longer than levodopa. It used to be the early treatment for Parkinson's disease. It seems to be reasonably effective for tremor and stiffness. Okay? We don't tend to use it now because these drugs do have fairly adverse psychotropic effects, and we're dealing with older patients who are probably on a whole range of drugs, so we're just making things a little bit more complicated for them, hallucinations, etc., confusion. Amantadine, antiviral drug, the only thing I'd say about it, it's useful for dyskinesia. So patients who have advanced Parkinson's, they've been on levodopa for a long time, you give them levodopa, they switch on and they're moving around with their dyskinesias. Memantine can help reduce the dyskinesias and therefore improve their balance and their mobility. Rasagiline, I just pass over that very quickly. It's a very mild stimulator basically in the motor system. Again, it's one of those kind of drugs we just throw in when levodopa starts to be less effective in the hope that it might iron out some of the kind of dips that people find with advancing years. The levodopa is still the most effective drug. My sort of take on levodopa is, if you want to have a good effect, a good treatment effect, use levodopa. Okay? And then given that most patients are in their 70s when they're diagnosed, 70s, 75 plus, levodopa is great, because for the first 10 to 15 years of using levodopa, they'll get a great effect. And all we're talking about is quality of life really. So there's no point in hanging about. I can put them on levodopa nice and early and give them quality of life. Yes, as the years roll on, 10, 15 years on, you get all the complications, so the on-offs, so these become unpredictable. You get the dyskinesias, and then you get patients who develop problems with blood pressure control, and levodopa can exacerbate that. Well, by that time you then have to start fractionating the dose, and it becomes quite complicated, and that's where a good Parkinson's nurse specialist can be there to work their way to build. I'll move over that. This is just to tell you that this is what happens with Parkinson's patients. That in the early years, you find you get a very good response to levodopa. As the years go on, because we get fewer and fewer nerve cells within the motor system left, we start to get dyskinesias emerging. So you take your dose, you get a peak of your dose, but you then go into this kind of area where you start stimulating the wrong sorts of cells, and you get dyskinesias. And in the end, when you get to this stage, you get a very small treatment effect, but a lot of dyskinesia. And it's a real difficult problem balancing it out for patients, because if you reduce the levodopa, they become stiff. And that's uncomfortable, it's not great, function falls off. But if you then increase the levodopa, they've got a lot of dyskinesia. So they're not stiff, but they've got the dyskinesias, their balance not so good, they fall, that kind of thing. So it's actually a really, really difficult stage to deal with. And there's a lot of complicated juggling of drugs, etc. that goes on. Sorry. I'm going to move on to these. I just want to tell you a little bit about dopamine agonists. So dopamine agonists basically stimulate different set of receptors from levodopa. They're quite useful. They're very good for ironing out the peaks and troughs that patients experience when taking levodopa after 5 or 10 years. The only key that I would tell you to pay attention to is this: impulse control disorders. So if you're dealing with any patients who you might be seeing who are coming to you for their treatments, it might be worth asking them about this. So by that, what I mean is impulsive behaviors. Okay? So dopamine agonists can induce impulsive behaviors. By that I mean sort of uncontrolled shopping, hypersexuality, gambling. Okay? And I have 2 patients over the last 15 years who have basically nearly got to being bankrupt. And to be honest, I wasn't aware that that was going on. It was only because the husband appeared in one case and said, actually, you've got to do something, because she's always shopping, she's using the credit cards, things are being ordered online, I know nothing about it until the bills come in. And she was on a dopamine agonist. So it might be useful when you're seeing patients, you just ask them about their treatments, etc. Perhaps you could ask them a little bit about impulsive behaviors. Might be obvious to you. Apomorphine is a dopamine agonist, again, quite useful. So when patients get to that point of lots of dyskinesias, and that's because they take levodopa in sort of 3 doses a day and they get a peak of dyskinesias, you can reduce the levodopa and give them dopamine agonist apomorphine, which gives you a smoother stimulation of the motor system without the peaks and troughs. The trouble is that you have to give it as an injection. So patients usually have a pump, a subcutaneous pump, and that gives you a sort of steady stimulation of the motor system and allows you to reduce the amount of levodopa. So I've kind of said this, and I just wanted to say it may not be necessary to give patients any treatment at all. So when you first start off with a patient, particularly younger patients, you make the diagnosis, but actually functionally they're okay. And you really just got to go with the patient and just say, well, you know, how does your condition affect you? What difference does it make to your day-to-day? Is it affecting your work? And that's the sort of discussion I'll have with most young patients. And actually, by and large, we put off treatment for about 5 years in younger patients. In older patients, as I say, don't waste time. If they've got symptoms, give them levodopa, give them quality of life. I've sort of alluded to that. Again, alluded to that. So these slides are all in your guidelines. What about freezing and falls? So freezing is about, patients will say, have you come across this? Freezing? Yes, I'm sure you did. In the gym probably, yes? You might see it in the gym. So patients come along to a doorway and they freeze, okay? So the legs get stuck, and sometimes they'll fall because the legs get stuck, centre of gravity goes over, and over they go, all right? So freezing is something that comes on later in life, in Parkinson's. And it can be quite difficult. And it's more common in crowded situations. So if they're out shopping, they find it difficult. If you have a house which has got lots of furniture, they find it difficult. So the usual thing is about giving them cues. So think to yourself, left, right, left, right. Get them going, so you can tell them to do that. I'll show you a slide of somebody who's devised something that helps him get going, a little video sequence. And sometimes patients can find visual cues helpful. So there was a patient who, we had at King's, who actually painted on his floor steps. He was able to paint these three-dimensional steps because actually patients are quite good going upstairs. And so he painted these steps around his corridor in his home. And he found that helped him because it gave him a visual cue. Falls, well, what can I say about falls? Falls are really difficult because when patients come to the clinic some years after their diagnosis, they say, well, I'm falling. And I just have a heart sink because I know I'm not going to do very much about falls. And all that happens is that I sort of write to you guys and I say, this chap will do some physiotherapy. Is there anything you can do to teach him about improving his core balance and anything to do to prevent falls? And you know, obviously it does help. You do classes, you often help patients with falls prevention. Same thing applies for Parkinson's, and send them to you, and hopefully we'll be able to prevent some of those falls and fractures. But it is about adapting. Canes, scooters, three-wheeled walkers, all those sorts of things. A lot of patients do develop cognitive problems as the years go on, something to be aware of. And indeed, dementia in Parkinson's affects about 40% of Parkinson's patients in the course of their condition. And of course, because they're older patients, it doesn't mean they can't develop Alzheimer's disease. So something to think about. And remember, the drugs can also slow down cognition. Psychosis is very rare, more often related to medication. So the first thing one would do is look at the medications, remove medications, and in fact, my spiel to patients after about 15 years of disease is, actually now's the time to start stopping tablets. Because the tablets start to cause problems, and among that is hallucination, confusion, falls, all that sort of thing. So it really becomes palliative Parkinson's care. So it's where you have to take away the tablets, have they adapted at home, what can the physiotherapist provide, what can the speech and language therapist provide, what about the dietitians, etc. So it's looking at the whole patient. Palliation. Depression is very common. Don't forget about depression. Identify it early. They respond well to the usual treatment of depression. Anxiety can be part of it. Restless leg syndrome, restless leg syndrome is very common anyway, but it is very common in Parkinson's disease. So you might want to ask questions specifically about it. Thankfully, most of the drugs we use for Parkinson's disease will treat the restless leg symptoms. Sleep disorders, I think I've alluded a little bit to that already. Always worth asking about sleep. There may be something you can do, so you could add into the diazepam for REM sleep behavior disorder. But a lot of it is about good sleep hygiene. All right? This is one of the other difficult things to treat. Okay, 10 minutes, I'll be through. And patients often, as the years go on, just because of their condition, they develop these autonomic problems. And treating this can be quite difficult. Patients stand up, they fall over. And one of the things that we often use is fludrocortisone and Myladrin. Okay, so chemical treatment, but also things like good fluid intake, increased salt in the diet, put the feet up in the evening, that sort of thing. Don't forget about the bowel and the bladder, basically. I'm going to skip over these because I want to show you the video I've got at the end. Sexual function. Again, all these things to ask about. It's all about quality of life, really. But it all gets affected, particularly as the years go on, because the autonomic system is involved increasingly in Parkinson's. Excessive sweating, again, that's part of the autonomic features. Again, drugs can also increase the sweating. And then just a brief note about surgical treatment. In fact, surgical treatment predated medical treatments. In the 1930s, people used to have thalamotomies for their tremors. And in fact, we still do thalamotomy for tremor. But as levodopa came in, surgical treatment went into the background. And surgical treatment has now come back into favour. So we have a big surgical program in King's. And it's really mainly for patients who have had all the medical treatments, and they now have disabling dyskinesias, and you've done what you can with the medications. Those patients can have deep brain stimulation. Okay, so providing they don't have any kind of contraindications, we put in these stimulators, and that can produce a very good effect. So it can reduce the dyskinesias, reduce the need for levodopa, and improve motor function generally, and mobility. So, physical therapy, I'll put that second, that should possibly be first, but education will come first, physical therapy second. Exercise, you can see all of these things are really important, okay? So the drugs are just one aspect of it. This is in your slide pack. Adaptive treatment is very important. Getting better and better, more and more electronic adaptations, physical adaptations to the home, etc. Think about all these things. This is what the community MDT teams do. Speech and language therapy, often voice can become very soft, important. And education. And I tend to signpost most people to the local Parkinson's Disease Society, to the nurse specialist, and to the Parkinson's Society website. Lots and lots of good information. Now, I'm just going to show you some slides which I got from Movement Disorders, which is an international journal. And this is about gait disorders, but more particularly gait disorders in Parkinson's. So I'm going to play it through, okay? And then we can play it through again. And I'm going to ask you what you think. All right? So just what you see and what you can describe. so, all right, let's watch this. Okay, so what did the first slide show? You guys see these patients?
Difficulty initiation of gait.
Sorry?
Difficulty initiation of gait.
Okay, so there's gait initiation failure. You right? So stand up, and then it's like motor system not kicking in. Yeah? What else?
Fascinating gait.
Fascinating gait. Yes. Okay. Anybody else? Sorry? Freezing, yes. What else?
Shuffling.
The shuffling, yeah. Fascinating shuffling, yes. What else?
Difficult lateral movements on his turning.
Yeah. So often they'll have this sort of turning on the spot sort of thing, all right? So that's a very common finding with advanced Parkinson's. He's a man who's had Parkinson's for over 10 years. Yeah. Was there anything else?
Often leaning to one side.
Sorry?
Often leaning to one side.
Yeah, and there's a little bit of a stoop as well. Okay, yeah. And in fact, when patients with advanced Parkinson's, they often have this, like this, camptocormia, right? Which is a consequence of loss of the axial tone. What else?
Once he got started, he was actually quite good.
Yeah.
Because it had arm swing and it looked quite
Yeah, it wasn't normal arm swing. Admittedly, it was a bit of a small room as well, so trying to get him going. But yes, he had more arm swing once he got going. What did you see on the floor?
Markings.
There were some markings, yes. So those are visual cues. Somebody put some markings down in order to, when he freezes, he's got a visual cue so that he can go. Right? And that's what the second chap was doing, wasn't he? He was giving himself a cue. So, do any of you use any of these things? Who has any patients who they give them visual cues? What did you use?
There's people use lasers
Yeah.
and tape.
Yeah. So of course, taping your floor or something is a bit difficult, isn't it? But the laser, this is a walking stick with a laser that throws a line in front, doesn't it?
Yeah, they even use like little lasers you can buy from the pound shop just to shine in front of the walker. A carer might have that.
Right. Yeah. Okay. So I'd come across some years ago someone told me about their walking stick where they had a laser on it and it threw a little red line in front. So it just gives you a visual cue. So any sort of visual cue might help. All right.
So the laser, is that going in the direction they're travelling in or perpendicular to them?
So it throws a line in front of them, direction that they're travelling.
Okay. How do you get symptoms? Okay. And are the symptoms the same, better, or worse?
Progressively worse.
Okay. Backwards.
Just watch this one.
Yes, I have problems with my eyes.
We're so nasty, aren't we? So, one other thing about that man that perhaps didn't, right at the end, what was she doing? Sorry, going back to the first sequence. The man. Sorry? Yeah, so she was doing what's called the pool test. Okay. So you know, as I said, as the years go on, you develop disequilibrium with Parkinson's disease. So on the pull test, you pull them backwards, and instead of stepping back to sort of save themselves from falling, they just go like a log. All right. So
is that before or after medication?
that can occur even when you're on medication. So that's when you've got to the stage of falls. So the sort of disequilibrium that comes. The lady before this one, what did that video seem to demonstrate? Shuffling gait, yes?
It's a bit high stepping on one side, and she always felt like almost had a foot drop.
Yeah,
Quite
yeah.
slow to come.
I think the key thing is she was broad-based, wasn't she? Yes?
Yeah.
So there's a lot of disequilibrium there. She was absolutely fearful of falling. You can see her holding on. And that's all. In fact, that's a lady more with vascular type of Parkinson's than anything else. Okay? So the disequilibrium is the key. She's absolutely petrified. And that was how she sort of, it started a few years prior and was progressive. Okay? But she had lots of vascular disease. This lady was, do you remember what I was saying about Parkinson's plus eye movement disorder? So you can see her face is not particularly expressive, so she's got Parkinsonism, and she's got an eye movement disorder. So horizontal eye movements are normal, it's the vertical eye movements, the supranuclear nucleus which is affected, and therefore she can't make these saccadic eye movements in the vertical. Almost done. There's a couple of people feeling very hot over there. It's just switched off, hasn't it? Now what this is demonstrating is that actually if you move the head, you can actually get the eyes to move. So the eyes do move, it's not that they're fixed. You can see this lady, right? So she's got a bit of a broad base. Tottering along a bit. But interestingly, she doesn't have the moving like that. Now, I'm not actually sure I would let her do this in my clinic, because if she fell over, we have 1,000 forms to fill in for a start. So she's unable to do a tandem walk. Now, look at this lady.
The other thing that I wanted is sometimes we find that vibration starts to shake, and not just the leg, but my body and the hands. So that's a very great vibration.
Okay, that's given you a flavour. So, what's the diagnosis?
That's the answer.
Yeah, keep running. What's wrong with her? Go on, you guys are going to see, you must have seen facial bias soon. What do you think? What did you see? So tremor seems to be her thing, doesn't it? But she also has this weird sort of bouncy trunk kind of thing, yes? I don't think I've ever seen that in real neurological disease. She has variable performance. She has a distractible tremor. Right? I mean, she can run. Now, if you're really ataxic, you're not going to run. You're going to fall over. In fact, this is a lady with a psychogenic movement disorder. Okay, and you can see how it can be really difficult to diagnose these. Okay, because some of them are so good. I mean, a lot of these patients actually end up for some years having a diagnosis of Parkinson's or what have you. They're on drugs, etc. And then you go, well, why is this not progressing? Why is it not going the way that I would expect a patient with Parkinson's? And so on and so forth. Okay? Interesting. Just keep your scanners always aware. All right? Good. That's as much as I would say. Sorry to run over. Sorry, it was a bit of a mammoth task. So yeah. You've got the slides anyway.
It's a hard topic to try and convince.
Yeah. Speak to them. Yes,
Laser. I had a talk one day from somebody who said he had laser, he had Parkinson's. He was about 61-ish, and he had laser, he had no one tremor, he seemed to be...
You had DBS, you mean?
Yes.
Yeah. So it is excellent, okay? But the DBS is invasive treatment. So we will always consider DBS for advanced Parkinson's. So we've gone through the stages of levodopa treatment, fractionating drugs, etc. They've got dyskinesias. Yeah, that's when to refer.
And what about the ultrasound?
Yeah, for tremor.
Yeah.
So yes, there's been these reports about using ultrasound, I think aimed at the thalamus, and it looks really interesting. And it's not just Parkinson's, probably for essential tremor as well. So I'm fingers crossed, because anybody with essential tremor, they come to me and I say, well look, you can try these drugs, you can try beta blockers, you can try gabapentin, you can try blah blah, suck and see, but I'm a bit nihilistic about it, because most patients will come back in the end and say, thank you, I've got all the side effects, but little effect on the tremor. Yeah? So, and tremor is the most difficult symptom to treat Parkinson's as well. So the motor system improves, but the tremor carries on, the stiffness, etc. improves. So, yes, ultrasound, I'm fingers crossed. 10 years it will be in the clinic, I hope. Any other questions? Sorry.
You mentioned that the levodopa is it requires good transport from the guts to the blood. Is that tested to have such a good effect that people have gut issues?
Yes. So
colostomy bag, is that then reduced?
So it's mostly in the jejunum that it's absorbed. And in fact, the real problems are with food. So if you have a high protein meal before you take your tablets, that can affect the uptake of dopamine across the gut. For the most part, even patients with colostomies, because there's a lower amount, don't tend to have a problem. So I've not come across that as a real problem with colostomy patients. So there's more people who perhaps have had upper gut surgery or upper gut problems, or if you're taking your tablets around the time you've had a heavy meal, that's not a good idea. Take your tablets well before.
Right.
Half an hour before. Any other questions? Okay, well, we're going to let you go then.
Not really.